Good morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Recovery-Oriented Services for Pregnant and Parenting Women with Dixie Morgese. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel as well. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and PowerPoint, go to www.fata.org and then to our Resource Center and then to our training library. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FATA's website. You will first need to register or sign into your account to complete the evaluation. Information you provide FATA as a part of registration remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Friday, October 1st. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide a certification number when you register with our site. Please note that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. Dixie Morgese has over 25 years of experience as a certified addictions professional and internationally certified alcohol and drug abuse counselor in multiple treatment settings. She earned her BA in Human Services, summa cum laude, from St. Leo University. Since then, she has developed and implemented systems of care to serve communities in the areas of maternal child health, health equity, family risk and resilience, HIV, trauma, and substance use. Dixie has worked with partners on local, state, and national levels to address social determinants of health and family resilience. She has provided consultation to the Center of Substance Abuse and Child Welfare, the Center for Study of Social Policy, and the National League of Cities. Currently, she provides technical consulting and training to Florida Association of Healthy Start Coalitions, the Northeast Florida Healthy Start Coalition, and the Volusia Recovery Alliance. Ms. Morgese recently retired as the Executive Director of the Healthy Start Coalition of Flagler and Volusia counties, a program that supports the well-being of pregnant women, infants, and families. Ms. Morgese identifies as a person in recovery. And now I'd like to welcome our presenter. Dixie, I will turn the presentation over to you.
Thank you so much, Rebecca. It's an honor to be here today. I'm excited about this presentation and thank you all for joining us today. So today's presentation is recovery-oriented services for pregnant and parenting women. And we talked a little bit about technology so that we can be successful in training on a webinar. The learning objectives for today, number one, understand the correlation between trauma and substance use disorder among women of reproductive age. 2, explore methods of creating a safe environment for discussing recovery options with pregnant and parenting women. And 3, compare and contrast models such as RAP, Seeking Safety, Smart Recovery, and 12-step programs, community and private treatment options for pregnant and parenting women in alignment with best practices. So I want to talk a little bit about the impact of substance use on women of reproductive age and their children. And I just want everyone to know there is a very robust amount of information on each slide, and there is a comprehensive resource list at the conclusion of the webinar. So I know sometimes in a webinar, afterward you'd like to reflect a little bit, and I just want you all to know that all the information that's used here has reference points that you can refer to later. So we know that use of substances by women of reproductive age has increased in Florida significantly in the last decade. We see increasing numbers of infants identified with symptoms associated with exposure to drugs in utero, NAS, which is neonatal abstinence syndrome, and now we hear the term used more frequently, NOWS, which is neonatal opioid withdrawal syndrome. And I don't want to discount fetal alcohol syndrome also, which is one of the leading causes of developmental disability in our children as far as intellectual disability goes. Parental use of substances is the #1 cause of child removal for children under the age of 5 in Florida. So it's starting to impact our courts, our child dependency system, and many aspects of our communities. The number of women who die due to substance-related causes within a year of having a baby has become a public health concern. Women who use substances are more likely to have an incidence of domestic or intimate partner violence, either in their history or in their current situation. Women who use substances are more likely to have experienced adversity in childhood. Children of parents who use substances are more likely to experience adversity in their childhood. And stigma and societal expectations can be barriers to women seeking and receiving recovery services. I share about my personal experience with substances as well as in recovery because there's so much stigma, and in my career as I became more successful, there were many times I felt afraid to tell people about my past, and I felt I was very vulnerable. And as I became more secure in my recovery and as I became more successful, I felt it was really important to share my history, to help women come forward and to help people, kind of overcome that stigma and recognize that, like any behavioral health concern, this is something that has treatment options, and it happens to many, many people. So the data, this is a little bit dated, but I like that it has 2 visual points. One is looking at the counts of neonatal abstinence syndrome as well as the rates. And I just want to say too that when we look at counts for neonatal abstinence syndrome, we're looking at the tip of an iceberg. These are babies that are identified and diagnosed at the time of the birth. So we know that if these are the numbers we're looking at as far as identification in hospitals, that the number of babies exposed far exceeds these numbers. But you can see that, across the state, the areas around Volusia County, Escambia County, Pinellas and Hillsborough County, Duval County are elevated rates, and you can see the counts. We see it also elevated around Pinellas County, up in Duval County. And, you know, I remember when I went to the Policy Academy, when the Comprehensive Addiction Recovery Act came out, we were looking at a slide of the state of Ohio, and you could see over the course of 10 years that these counts and these numbers, just little by little, the whole state became this dark color. And I think it's really important that we work on helping all women of reproductive age um, seek and find recovery and destigmatize substance use and trauma and behavioral health issues, so that we can maybe have a different outlook and get those get those back to a lighter color. Also, Florida child removal rates, our numbers were high. There were, you know, in relation to the nation, and there were a couple studies done. I thought this was very interesting. This was a study and analysis that was done on drug-related causes for removal during 2012 and 2015. Again, a little dated, but it does show the prescription issue we were having at this time. We were really experiencing issues with pill mills, people being able to walk in and just get prescriptions, a lot of prescription drugs being given in dentist offices and emergency rooms, and we're still kind of battling this very easy pathway to getting prescriptions for opioid medication, and what it can do for someone who feels relief from getting a drug prescription and then is unable to stop using, and then it starts affecting their parental capacities. I think one of the things that's really been startling, and it's woken everyone up, is the increased amount of drug-related maternal deaths. And PAMR, which is the Pregnancy Associated Mortality Review, which is conducted by the Florida Department of Health, has been looking at these findings and really trying to get some messaging out there to make physicians and clinicians more aware. It is now the leading cause of death to mothers during pregnancy or within 1 year after the birth of their baby. In 2017, drug-related maternal death accounted for 1 in 4 maternal deaths in Florida. There are now as many maternal drug-related deaths as deaths due to traditional causes of maternal mortality, so all those things that we consider related to a woman having a baby that may cause death afterward, have now been exceeded by drug-related causes. 75% of maternal drug-related deaths occur after the baby is born and the mother has been discharged from the hospital. So some of the risk factors, stigma and bias, make it very difficult for women to discuss their condition. Fear of child removal, fear of incarceration, fear of judgment. More than 30% of women with opioid use disorder have some kind of underlying depressive disorder that can complicate care during the perinatal period. This is really significant because many of these women, prior to their reproductive age, were already experiencing some form of depression and may or may not have been identified in our systems. Women with opioid use disorder who decide to stop medication-assisted treatment, methadone, buprenorphine, other types of medication-assisted treatment, they're at risk of relapse and potentially fatal consequences and damage to the fetus. Loss of Medicaid or other health care benefits, such as through fetal or infant loss, may result in reduced access to the needed medication-assisted treatment or other services that may be needed. So it's one thing that we have worked on collaboratively as a state. Right now, if a child is removed and the court's goal is not termination of parental rights, It was a huge accomplishment that women can keep their Medicaid during that period. But if a woman has a pregnancy loss or an infant loss and was only eligible for Medicaid because of her pregnancy, then she may start some kind of treatment, or an OBGYN or other clinician may have identified services that were needed and connected her, and then she loses a primary payer source for those services. So it's one of those risk factors that we need to be aware of and make sure that when we're referring women so that they can get ongoing care, that that there's a payer source and that her Medicaid hasn't been discontinued or won't be discontinued. This happens also when women are incarcerated. So pregnancy associated mortality rates, if you look at this chart here in Florida, you look at the change from 2008 to 2018, you can see that the number of drug-related causes has increased, and it's now tied for the #1 cause of maternal death. Also down at the bottom where you see the legend, I just want to note that the initials MVA stand for motor vehicle accident. So another area we look at where the is pretty significant is in intimate partner violence with women who are identified with substance use. 1 in 15 children are exposed to intimate partner violence each year, and 90% of these children are eyewitnesses to the violence. So we start looking at the multi-generational nature of children's exposure to trauma. 1 in 5 women in the United States have been raped in their lifetime, and 1 in 4 women experience severe intimate partner violence and or intimate partner contact sexual violence. And this is important because when we look at the higher rates of women with substance use disorder who have either a history of intimate partner violence or domestic violence, then when we compare it to the average, we know it's higher. So when we just look at those numbers, 1 in 5, 1 in 4, we know that in our clinical experience, when we're working with women, we know that the likelihood of them having experienced some kind of partner violence is very high. 37.9% of Florida women experience intimate partner violence, intimate partner sexual violence, and or intimate partner stalking in their lifetimes. According to the American Society of Addiction Medicine, or ASAM, substance abuse is involved in about 40 to 60% of all intimate partner violence incidents. So we see that correlation, and we should be keenly aware, because it can make it very difficult for women to connect to recovery, or for them to be able to follow through when we're working with them on connecting them to services. Domestic abuse victims are 70% more likely to drink excessive amounts of alcohol than those in healthy relationships, and that's the data that we have. But for all substances, at the end of the day, at least I can speak for myself, when I used in the beginning, I felt better. I had no way of knowing that my mental health had been so impacted by trauma and by relationships that I had been in. I just knew that when I used, I felt better. I felt more relaxed. I felt like I could talk to people. I felt like I could function. And I think it's really important for everyone that's working with women that we are asking the question about what constitutes a healthy relationship, what their level of safety is where they are, and also that we are helping them to destigmatize their experience with intimate partner violence. Anytime we're looking at something where we see this high rate, then I say, if we were all talking about it, what we would find out is that in a room of a few women, we're going to find someone else that has had similar experiences. So we talk about trauma, and most of you are probably very familiar with trauma and with ACEs, but I think it's really important to see it in context of pregnancy and parenting. But we know that trauma is the individual response to an event. We know that each person processes traumatic experiences differently. Some people may adapt very well and move on and really not be that affected. Some people may uh, have severe psychological or physiological responses to other things because of trauma. We may have long-term reactions, which can include things like unpredictable emotions and flashbacks, and then strained relationships and physical symptoms. And again, I speak from my own experience that having intimate relationships was very difficult for me. Controlling my emotions and self-regulating when trying to just deal with normal conflict in relationships was very difficult for me. And it was a long road of recovery, and I am very, very grateful for people in the behavioral health world who were patient with me and understood that it wasn't personal. I wasn't trying to be resistant. I wasn't trying to be mean. I was really not able to regulate how I responded because I'd had so much experience in my past that kind of set me up for this fight or flight or freeze scenario with them. The Adverse Childhood Experiences Study, or ACEs, was one of the largest studies focusing on the impact of adversity or trauma on physical health. Trauma often results in maladaptive coping behaviors, so our brain does a lot to try to help us stay safe. And sometimes in the social world, even though it makes sense to the person who's doing it, it doesn't make sense to a lot of the people around them, and it can be very off-putting, and it can really result in isolation for people. And the individual may or may not be aware of their responses to others. So they're reacting to situations, but they don't necessarily tune into the cues of others and realize how much it's damaging their ability to succeed. And this is especially important when we're looking at parents dealing with their own children or their partners or our community systems. For women, pregnancy and childbirth may connect to past events of trauma, especially sexual trauma. So the whole process of childbirth, the whole process of going to an OBGYN, laying on your back, putting your feet in stirrups in your nakedness is probably the most vulnerable position that a woman can be in. It may result in a woman not adhering to her appointments, not coming back for prenatal care, not being forthcoming with the person that is there really in an intimate setting to provide um, help for her. But consequently, it may also be the opposite. So a lot of times it may be the OBGYN or the midwife that this woman talks to for the first time about her sexual trauma history or intimate partner violence. So it's really important that we have strong relationships with our prenatal clinical providers so that they can rely on us to support them in their care of pregnant women, parenting women. And it's also, really important that we forge these partnerships. There's some progress being made in OBGYN's ability to access psychiatric services so that they can still be sort of the primary person that's caring for a woman, but also manage psychiatric disorders and other disorders during the course of the pregnancy and beyond. And so obviously it potentially exposes children to trauma or adversity. If a parent, if the mother is really having reactions or responses that interrupt her ability to have an intimate relationship with her infant, because we have to have this very close relationship with this new being coming into the world that relies on us for everything. Um, it may make that initial parenting very difficult. We need to remember that. So I think it's really important that in our work we be reflective. both of ourselves as well as the people that we work with. So I always like to include questions for reflection, even though on a webinar we don't have the opportunity to talk through the reflection. I encourage people to really be reflective in their work. So just thinking about the kinds of things that make us nervous. For some of us, it might be walking in the dark near our house, um, or public speaking, or spiders. It could be so many different things, but it may be very connected to some kind of memory that we may or may not be consciously aware of. And one of the things we know is, just saying the word nervous is really indicative of changes in our body, in our physiological response. And, I just think about some of the night terrors that I had when I was first getting clean. It was like my brain was trying to process trauma in my history, and it was, um, very difficult for me to sleep. And I would wake up with all these physiological responses, my heart beating fast, my, uh, vasomotor system affected. I was sweating, um, and I felt afraid. And it was a nightmare. It was something sometimes I couldn't even remember. But I think it's important for us to connect to our own um, feelings of fear or anxiety um, when dealing with things that make us feel afraid or traumas from our past, because we respond differently when these things happen. And for me, I try to remember that when I'm working with someone who may get very angry or may just shut down. Um, that really, when we're talking about trauma-informed care, it's not enough to be trauma-informed. It's really important to be trauma responsive. And one of the best ways is through empathy. We all have something that makes us feel afraid. And if we can connect to somebody whose fears may seem irrational, given the setting or given the situation, um, it doesn't have to really make sense to us. The goal is to try to help someone reflect and let it make sense to them. So I really love Nadine Burke-Harris, who became the Surgeon General of California, is a pediatrician who found out about the ACEs study and really had a revelation. And she did a TED Talks. And so I am going to share that with you now. And just think about some things related to trauma as you watch her TED Talks video. So I could see that there were a couple of you who couldn't hear the audio. I encourage you to go to TED Talks and view the entire video. And we are going to go kind of a review of some of what she said, because it's important. And when we think about, the high number of people that have ACEs in general, and the high number of women that we know have experienced some kind of traumatic event with intimate partner violence or sexual violence, then it should be informing how we are considering working with the women in our practice or in our environment. So we want to consider trauma in childhood. I share this very openly because it was a hallmark moment for me in my role as a clinician. I had been counseling women for years. I was an active member and still am of Narcotics Anonymous. I spoke nationally. I sat on advisory panels, and my intimate relationships and my struggles with them brought me to my knees. I ended up going to see a therapist, and I share this because I think it's important. I think many of us experience similar things. And I shared with her a gang rape that happened to me when I was 12 years old. I had never told anyone because I defied my parents, my mother's wishes, and I went to David Park Teen Center, and I had been told not to. And in my little brain, I thought, this is what happens when you disobey. And so I never said anything to my parents. And finally, during the course of therapy, I shared. And I just think it's important um, also to share that I can tell you the smells. I can tell you the smell on different men's breaths. I could tell you the plants that were there, the time of day, the time of year, the feeling of the gravel on my back. I It's all in my brain. And the therapist said to me, "Do you see a correlation between the gang rape and the onset of your substance use within a year of that event?" And I said, "Well, no, because they didn't really hurt me." And what a good therapist she was, because she sat there and let that roll around in my mouth for a minute. Here I was, a person counseling other people. And I just started to cry. And she said, "You've been working on that your whole adult life. They didn't really hurt me." And so, how each person is translating traumatic events in their life is very different. But I want to share because I think it's important that people know I was really hard on women. In my mind, I had overcome, I got clean, I was doing things. And so I was not as empathetic as I should be. One would think that that experience would have made me understand, and it didn't. I think it made me even harder on other women. And what Dr. Burke Harris said is important. Duration and intensity of trauma is important too. I had many traumatic events after that one, mostly in my young adulthood because I was using and I was, in very risky situations. But I didn't have a parent abusing me. I didn't have, uh, you know, the intensity and duration of trauma that some of the people we're working with have. And it's really important that we be informed and understand that just because we went through something and are able to either be in recovery or overcome or work or whatever, that the person sitting in front of us who's not doing those things may have a whole different response to trauma. And so I share that because I'm sure we all ended up in this field. because something brought us here. We didn't wake up and say, I'm going to go make a lot of money in behavioral health because there's not a lot of money in it. We come into this because of something. We want to help others, but we also kind of come in with sometimes our own healing needs. So I share that because our self-awareness is ever important. Trauma in adulthood, including intimate partner and domestic violence and human trafficking, should be considered. Many of the women that we work with may be selling their body for drugs, selling their body for money. And then again, if they can tune it out and say, well, they don't really hurt me, then it just becomes a compounded experience and something that they may almost be used to. They may have undiagnosed conditions, such as depression. I never realized that I was depressed. I didn't know how anyone else felt. I didn't know, uh, if people struggled with just having a social conversation or when the kids were dancing. It, I, I didn't feel like the kid that could get up and dance. Um, when I started taking a drug, I did. All of a sudden, I had a release of some of these inhibitions. So, there may be undiagnosed conditions there. Shame and stigma. Nobody could have shamed me as bad as I shamed myself. But I was in many clinical settings where I felt ashamed. I don't want to say whether it was the interaction with the uh, person in the behavioral health setting, but I do know that when someone helped me feel accepted and helped me feel hope, it made all the difference in the world. Fear of the system. I'm grateful I didn't have my children when I was actively using. I got clean and then I had children. But that fear of the system, fear of child removal, fear of, being locked away, fear of, many consequences that our systems may impose on people that are using should be considered. Asking women, what is your biggest fear of seeking or getting help? Previous removal of children by protective services. A lot of the women that I've worked with have had previous removals. It makes them terrified when they're pregnant that it's just going to all um, play out again the same way. And sometimes these are women in recovery. These are women who've been clean for a year and they're still very traumatized by a previous removal of their children, and they makes it hard for them um, to seek help, and it may also make it very difficult for them to stay clean after the birth of another child. Relapse can be very high following the birth of a child. Body image and nutritional needs, especially we're talking developmentally about young women. The idea that their body has sort of morphed during a pregnancy and they want to be attractive and want to, feel good about themselves. And some may have really uh, big struggles with their body image. And also focus on concrete needs, the relationship to vulnerability. So I just want to say sometimes we want to help a woman get safe and get her, put up in a hotel. A hotel may be a huge trigger for someone who turned a lot of tricks, did a lot of drugs in hotel rooms. And so, just helping women identify and link to concrete needs that are also not going to trigger trauma is important. Also, not putting women in a position where they have to rely on a man, a dope dealer, someone who will exploit them in order to get their concrete needs met. And I think that's one of the biggest challenges in behavioral health, that we don't all have an unlimited budget to try to help someone get their concrete needs filled. And many times we're a referral based system. So we hand someone a referral and say, go here, go there, call United Way. And sometimes that's not, sometimes women need more active helping. It's not the easiest thing for them to do for many reasons, transportation um, being one of them. The availability of resources, especially in some of our rural areas in Florida. We have people who are working with moms and don't have a lot of resources in their county or in their region. and have to really stretch outside of their geographic boundaries to try to get help. Financial limitations, oftentimes when we come into recovery or we've been out there using, we've exhausted um, all of our finances. And so telling someone to go here or go there um, may really have its own limitations because there's no money, there's no access to money. And think about it when you're pregnant, when you're in your 38th week of pregnancy. I've had people say, well, isn't she working? And I'm thinking, well, see if you can get hired at 38 weeks of pregnancy. If anything, a lot of the women we work with who are in the food industry or they're in the hotel, hospitality industry, they get left off the schedule. So when they need money the most, now they find themselves with no job. And then they're ashamed to tell people that they're not working or that they don't have money. Developmental concerns. I think it's really important too, when we take history on women that we work with, finding out could they have some fetal alcohol spectrum disorder themselves. If they had a mother who drank or used, then they may also have some neuro developmental issues that could impact their ability to parent or their ability to adhere to recommendations. Physical health, I just want to say too, women who use substances, depending on the substances, may have a lot of dental issues, which are very painful. It's really hard to tell somebody not to use when they're in a lot of pain, physical pain. So making sure we know where the resources are to help women with some of their physiological needs like dental, reproductive health, and what their reproductive history is. Disproportionately, the women that I have worked with, and I'm sure there's research out there somewhere, but I don't have it at my disposal right now, but conditions like endometriosis, um, from my experience, seem higher. Uh, Vasovagal syncope, women who will pass out, um, when having a medical procedure, have seemed much higher among women who have trauma in their history or substance use. Also conditions related to needle use and chronic medical conditions such as we see women with endometriosis during their, endocarditis during their pregnancy, which is when the heart has been impacted by sepsis related to needle use, using unclean needles, hepatitis, HIV. These are all physical conditions that we should be very aware of, especially when we're working with a pregnant woman. Infections on the skin or infections on the skin of a partner who may be sleeping with them, exposing them to things like MRSA, and then developmental concerns of both the parent and the children. So Dr. Harris talked a bit about the ACEs, and so I'm going to go through these slides fairly quickly. But the adverse childhood experiences, these are potentially traumatic events that occur in childhood, and for the purposes of the study, it was children between the ages of 0 and 17 years. These included things like experiencing violence, abuse, or neglect, witnessing violence in the home or community, having a family member attempt or die by suicide, and also included were aspects of the child's environment that can undermine feelings of safety, stability, and bonding, such as growing up in a household with substance misuse, mental health problems, and instability due to parental separation, or household members being in jail or in prison. And as Dr. Harris, so eloquently shares in that TED Talks, ACEs are linked to chronic health problems, mental illness, and substance misuse in adulthood. ACEs can also negatively impact education and job opportunities. So what she said is important. About 61% of the adults surveyed across 25 states said they had experienced at least one type of ACE, and nearly 1 in 6 reported they had experienced 4 or more types of ACEs. And, if we could prevent this adversity in our children, we would also be helping the overall health of our future generations. And so, really helping to promote positive parenting, really helping parents prevent traumatic events for their children is in our best interest from both a physical health perspective as well as an economic perspective. We know that some children are at greater risk than others, and I want to say that in the ACEs study that we keep referring to, there are certain aspects of it that are not included that we should be considering, like racial and economic injustice, bullying, prostituting, and human trafficking. They're not measured in this study. They weren't asked about that. There were 10 questions, included the elements we showed before, but there may be many other conditions that people experience that could be traumatic. And I know women that have had experiences with the birth of a child in a hospital setting with medical providers that were very traumatic. And so, you know, finding out from people what kinds of things they've experienced and what may be affecting their ability to be in recovery or get the maximum benefit of recovery is really important. We know that the economic and social cost to families, communities, and our society totals hundreds of billions of dollars each year when we think about ACEs. This was the pyramid that really kind of showed how ACEs are strongly related to development of risk factors for disease and well-being throughout the life course. And, as we move forward in this webinar, I think it's really important that we identify that these are not predictive factors, that there are people that have a high ACEs score that are very successful and who don't have these physiological responses. And what we really want to talk about is what's the difference? What gives people the opportunity to not make these aspects of their life predictive in nature? So it's also, they didn't choose anybody they considered very high risk. Most of the participants were over 50, most were white, and most had attended college. And you can do your own ACEs score poll. You can go out to the website and see the ACEs study. I encourage everyone to know your own ACEs score so that you can really identify some of those things that may be affecting you on a day-to-day basis. So these are the questions, and I don't want to go deeply into them, but basically up until the age of 17, asking about if people had enough resources, if they lost a parent, if they lived with anyone who was experiencing mental illness, if they were living with someone who was using substances, if they were hit or punched or threatened, if anyone went to jail. Um, if people were cussing at you or insulting you or putting you down, um, if a parent or adult ever hit or beat or kicked you or physically hurt you in any way, or just feeling unloved, that there was no one that told you you were special, you were important, and then also unwanted sexual contact. In this picture, I had the opportunity to meet Dr. Folletti, and it was, I just felt like I had been on a pilgrimage to Tampa to hear him speak, and I was able to speak with him afterward a little bit, which was such an honor. And this is one of the studies that he shows to really share the breadth or illustrate the breadth of what people go through. The original ACEs study was really to look at obesity. And in this particular case, there was a history of sexual abuse. She was able to lose over 250 pounds within a year, and within the next year, she gained it all back. And the striking thing about her gaining the weight back was that it was very intentional. Some of those underlying traumatic experiences, there was something about eating and her weight that made her feel much safer being heavy. She didn't like that men were paying attention to her. She didn't like the different social experience. And so I think it's really important when I think about recovery, how grateful I am that in my recovery, when things felt very unusual to me, like getting my license renewed before it expired, or getting a new tire on my car before it blew out, that seemed very anticlimactic and almost made me feel a sense of remorse, which may not make sense to anyone else, but to me, I needed to have a lot of faith and a lot of encouragement that these were the right social things to do, and that I was capable of doing them, and that I was, on the right track, even though everything felt like I was an alien, like these were alien things to do. So we talked a little bit about this substance use disorder and trauma. Initial exposure to substances may provide a tremendous sense of relief. For me, I know it did. All of a sudden, I felt relaxed. I felt like I could sleep. I felt like I could talk to people, like I could dance, like I could laugh. Things I hadn't done in a long time. And I would say that, people may wince when I say this, but if I had not found drugs, I really think I would have found suicide. I was very dark. I was very sad. And, I didn't correlate those feelings with the trauma that I experienced, but I was not in a good place as a young person who already had raging hormones and, all the things that happen to us when we're adolescents. And so that initial exposure provided tremendous relief to me, and what it made me do was say, I need more of this. It results in maladapting coping mechanisms, the attempt to manage those symptoms or self-medicate. I would have stolen drugs out of anybody's medicine cabinet, and I would have probably taken anything that looked like it might get me high. And so, I think back, I could have taken blood pressure medication or things like that. There were so many risk situations and so many ways that I, you know, coped in a maladaptive way that, each person's experience, these maladaptive coping mechanisms morph over time and may seem very normal to that person, even though the people looking at them say, oh my gosh, can't they see they're killing themselves? Can't they see how harmful this is? Our receptors in our brain respond, our tolerance increases, and then symptoms of withdrawal can be present. So it's painful to withdraw, especially opioid withdrawal. On the streets, we call it dope sickness, and it makes every cell in your body feel like it's on fire. It affects your vasomotor system, feeling like you have fever and chills. So it's very, very uncomfortable once you've built tolerance and you're experiencing withdrawal. So, people may be really trying hard not to use anymore and aren't successful because the physiological pain of it is overwhelming. Like I said before, trauma responses can seem so illogical and counterintuitive to us looking, but they usually have their connection to something very uh, explainable when we know that person's history. And that becomes the challenge, really peeling back those layers and helping someone feel safe enough to tell us. And then the partner issues for people who inject drugs can make engagement and motivation for change very difficult. And I say that because shooting up with someone is an incredibly intimate experience when it's also a partner you've been with for a long time. And so we see women who come into recovery who miss that intimate engagement with their partner. And then if they have had a treatment episode and then they're back with that partner who's still injecting drugs, even though their obsession to use or get high may have reduced because they have been in treatment and they've detoxed their body, the emotional attachment may create a new obsession and compulsion to use. So it's really important that we understand the relationship with her partner and what the plans are as she works on recovery in being connected to that person, especially if that person is the biological father for her child. I thought this was really interesting. when I looked at this study, so the CDC was looking at a lot of pregnancy-related issues, and they looked at prescription drug use among women on Medicaid and women who are privately insured. And within a 1 year, oh no, I'm sorry, between 2008 and 2012, on average, 28% of women aged 15 to 44, which we consider reproductive age, that had private health insurance had a prescription for an opioid medication within a year, and 39% of women enrolled in Medicaid filled a prescription written by a healthcare provider for an opioid medication. And the reason I say this is important is because when I had my first prescription for Percocet, I thought I had found a dream because all of a sudden I felt better. And my goal was to find more of that. And so if we have clinicians who are not fully understanding someone's history, they may be very easily prescribing opioid medication for a dental procedure or a surgical procedure, and that person may have the first relief they've had in a long time, which may really start that ball rolling toward prescription drug abuse and then street drug abuse. And so I think it's really important to ask people, have you ever been prescribed an opioid medication and what happened? We used to see people in methadone clinics or on MAT many years ago. We were getting them on those medications to stop needle using behavior. Now we're seeing more people who started with prescription drugs and get on buprenorphine to get off of the prescription drugs. We talked a little bit about the brain. I wish someone had told me about my brain. I would have felt so much less shame to understand that when the reward circuit of the brain and the extended amygdala that controls fight, flight, or freeze were the people that had the gavel in my head, made it really hard for me to stop using drugs because I kept seeking the reward, and the trauma of my past was kind of overshadowing any ability my prefrontal cortex had to think and plan and make these executive decisions. And when we use, the prefrontal cortex is kind of diminished. And so when I could understand that, it really helped me understand that this was an obsession that I experienced and I didn't have to act on it, which is the compulsion. And so, the fact that, drug addiction is an obsessive compulsive sort of disorder, when I understood more about how my brain was working, I felt less shame and I felt more empowered to put my prefrontal cortex in charge so that I could make better decisions and so that I could, be part of the living world and not be out there like a reptile, that reptilian brain that just was moving everything I did and made me react to everything that was happening. I had had many treatment episodes and no one ever explained my brain to me. So I encourage you, if you're working with women, help them understand what's happening in their brain. And then obviously the other parts of the brain we need to be very concerned with are the parts that work all by themselves, the autonomic system, because when we take too many drugs, then our ability to breathe, our heart rate, is also diminished, and that can result in overdose. And consequently, we have a lot of push to get people to carry Narcan so that when the amount of a drug that they take affects their body's ability to do those things, we can kind of negate that through the use of Narcan and at least help them live until recovery is possible for them. And then also, euphoria. First time I took Percocet, I felt this tremendous sense of well-being. And it's funny because if you really look up opioid or opiate, it says provides euphoria and a wonderful sense of well-being. If you've been depressed or full of anxiety or, battling illness and you didn't really know it, you take a pill that helps your brain feel that way, and here there's these pleasurable changes that occur. And for me, I felt like I had found the answer. And so it's important that we understand how the brain is functioning. So there's this cycle of behaviors that we see. So the intensity of drug effects results in this flatness. So the minute I woke up and I wasn't high anymore, I just lacked any motivation. And I just felt like really what I needed to do was get more drugs in me. I felt like I couldn't really approach a day and get anything accomplished unless I got high. And then it made me feel like I couldn't really enjoy things that I once enjoyed. I remember once when I was using, and the next day I woke up, and I don't even remember where I woke up, but outside my window there was a playground. And I remember looking in that playground and seeing children look so carefree and asking myself, did I ever feel carefree? It's all I wanted. I wanted some feeling of freedom or feeling carefree. Um, and the continued use sometimes just gets people to normal. So people who are addicted to opioids, they take the drug just to get their central nervous system to a place of normal. Just like with alcohol, a person that's not drinking and their body has become dependent on alcohol will start having tremors. They will start responding. Their central nervous system can ultimately have a grand mal seizure in withdrawal. So it gets to a point where you're taking the drug just to feel normal, which of course then makes drug seeking behavior more severe, willing to do anything, sell out anybody, tell somebody anything just to get the drug. When I used to work outreach, I learned and I knew from my own experience that when I saw someone actively looking to use, I would give them a card and I would say, when you get tired, call me. Because trying to interrupt someone on a mission to use is really futile unless you have a lot of resources at your disposal, or you physically detain them. So when a person's on a mission to use, it is a tremendous sense of seeking and anticipation. Even in the line at the methadone center, I remember going there to pay for someone's dose and feeling that sense of anticipation outside, and it almost triggered my addiction. I felt like, God, I remembered that feeling of anticipating getting high. But ultimately, what happens is we have these increased feelings of shame and isolation, and then fear of becoming overwhelmed, fear of what's going to happen if the drug gets taken away. And Dr. Folletti, something that really struck me. He said, we keep trying to take away something that almost works for people. And that's how it felt for me. It was causing havoc in my life, but it almost worked to make me feel better. And that fear of taking something away that's almost working be debilitating to someone. It can make them very resistant to getting help or to getting treatment. So go ahead and throw pregnancy, birth, and a maternal mental health in there. You know, I have been in meetings where I see women come in pregnant or with their infants, and I think to myself, what a big job. I got clean before I had children. It was hard enough. I cannot imagine trying to get clean while being pregnant or with a child to take care of. I also realize from working with many women that it can be a tremendous motivation to have a new being in the world and a new beginning. And so, reckoning somebody with trauma that may occur during childbirth is really important, helping them have a good birth experience to sustain that kind of motivation. Understanding hormonal changes. Women with substance disorder, just on a documented basis, have a higher incidence of postpartum depression. The guilt and shame and stigma that they experience may feel overwhelming to them at times when they're looking at their baby or they're thinking about their baby coming and they're wondering, what do I tell my child about her birth? What do I tell her about being a baby in the NICU because I couldn't stop using drugs? These are things that women share over and over again were so difficult for them. And then removal of an infant or other children. So you have a woman who's got a higher risk for postpartum depression and then this tremendous loss and grief when DCF does have to remove the infant and place the infant somewhere else, maybe with a stranger. And so, especially women that may have had experiences with foster care themselves, that is their worst nightmare coming true. Anyone who's had a baby or seen a baby in the neonatal intensive care unit knows it's terrifying. There are health professionals coming in and out. There are machines everywhere. There are babies that are really frail, and it just magnifies this experience of look what I did to my baby. This feeling that so many women have. And not always are the staff in the NICU in a place where they can be supportive. They try to keep infants alive, and some of them have their own biases about the women that they're looking at, thinking to themselves, look what you did to your baby. And the woman knowing that. Or when she goes out to smoke a cigarette and comes back and they, may shame her for coming in smelling like tobacco. There's just so many things that women have shared that they face, that are a different experience than just coming in and trying to seek recovery, not being pregnant or postpartum, trying to learn how to care for an infant that is probably much more fussy than the average infant. There's a whole other training on neonatal abstinence syndrome, or neonatal opioid withdrawal syndrome. But these are infants that need a lot of help soothing and self-regulating. And so mom needs to learn a lot about how to care for an infant like this, and also sleep interference. So I will say that one common theme among uh, women I've worked with, especially those with trauma in their history, which is most of them, sleep is such a challenge, just getting enough sleep or sleeping through the night without some kind of night terror or night paralysis. And then here comes a baby and their sleep is being interfered again, like every 3 hours, a baby needing to eat or crying or needing a diaper change. And so even women who are in recovery are at risk for relapse after they have a baby, especially if they have a mental health diagnosis that they're dealing with. This movie, it's called Getting Real. It was done by the Florida Perinatal Quality Collaborative here in my county, Volusia County. They have 4 films that I encourage people to use to talk to other women, and also that I encourage you to share with clinicians. So, in summary, before we take a break, I hope you enjoyed that film. It was really a joy to make with these moms in recovery. But just remember the ACEs. Make sure you search for strengths and protective factors. We're going to talk about that after the break. Create safety and support, not dependence or judgment. Use motivation and engagement. Do not try to coerce someone that's had trauma in their history. It's very much a trigger. Develop rapport with trust and advocacy. Use reflection and reflective practice for all staff members. Use recovery-oriented language, and we'll go over some of that language after the break. Consider trauma as a reality for all staff members and persons receiving services. And then just remember that people who've had adversity in their past um, are more likely to have some kind of depressive disorder. And the most important, these are not predictive factors. People can experience ACEs and be very successful in life. So we're going to go ahead and take a break. And when we come back, we'll talk about recovery.
Thank you, everyone. We're going to take our 5-minute break and we will all come back at 11:25 to hear more from Dixie. Thank you. Welcome back to today's webinar. Dixie, if you are ready, I'm going to go ahead and pass this over to you.
Okay, thank you, Rebecca. So we summarized really the impact of trauma and the adverse childhood experiences. And I think it's really important to remember that they're not predictive factors. And so really focusing on recovery and starting to develop better language about recovery. I do want to share that as a woman who was in treatment 4 times, there were times that that treatment was very kind of punishing. It was often fraught with kind of shaming behavior, and that was when I was very young. But as I have been on my journey with addictions counseling and working with treatment centers, I am so excited to see the changes that are taking place in the breadth of how we interact with people who are identified as having substance use disorder or really trying to find a path to recovery. So this is the SAMHSA definition. Recovery is a process of change in which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And so here are some basic, points to remember. There are many pathways to recover. Not everyone gets it through treatment. Not everyone is quote unquote successful in treatment, but may later find a pathway that works for them. Recovery involves a personal recognition of the need for change and transformation. It doesn't help that everybody else sees it. It's when the person themselves really wants to change that it's so impactful. Recovery is holistic and it has cultural dimensions. Every person sees their path different based on where they were born, who they were born with, what their family of origin is, and what brings them strength, what their traditions are. Recovery exists on a continuum of improved health and wellness, so we always look at it on a continuum. I love asking women, what's worked for you before? And when they say, I had this period of time, it was the best. I did this and this and this. It's very hard to find a path to recovery in isolation. And so feeling like there's people in your corner is really important. I just want to emphasize again, shame doesn't work. If it worked, we'd all be really well. So really helping someone know that you're in their corner, that you won't participate in things that are hurtful to them, but that you're there to help them find the pathway of recovery that works for them. It emerges from hope and gratitude, and that's what I love about the film. Um, both women shared how much it meant when someone said, I know you're going to be a great mom. I know you can do this. You have potential. Those are the anchors on which good recovery is rests upon. It involves a process of healing and self-redefinition. We get to reinvent ourselves in recovery, and we get I just did what they did for a while because I had no clue, what else to do. It involves addressing discrimination and transcending shame and stigma. Um, there's a lot of words that we associate with people who are using that are very damaging and bullying. And, we really need to change the community. It's not a, there's a great film that really showed, a research experiment with rats and how it set a trajectory for how we worked with people who were using substances and how new research and work with those rats showed us that when rats were put in social environments, their propensity to use was much lower. Um, and it's a reality. It can, will, and does happen. And as we get older too, our frontal lobe more. Sometimes people that had a hard time finding recovery when they were younger, after the age of 27 or 28, find a much clearer pathway to recovery. So remember development. The term recovery management, it's a philosophical framework for organizing behavioral health treatment and recovery support services across the stages of pre-recovery identification and engagement, recovery initiation and stabilization, long-term recovery maintenance, and quality of life enhancement for individuals and families affected by behavioral health. So in recovery management, the values and guiding principles are really important. It needs to be person-centered. I've dealt with treatment centers that have said, well, we can't give this woman this because then other people will think we're playing favorites. Every person that comes in is different, and they deserve their own person-centered plan that is very self-directed. It needs to be anchored in the community. We can't just isolate ourselves, have a treatment episode, and then go out into a community and think we're just gonna, you know, that we're cured. It doesn't work that way. We need uh, all of our recovery services to be anchored in a loving, caring, and embracing community. Holistic approaches, everyone sees themselves in the world differently, and looking at their whole person is really important. Looking at the family and other support involvement. Like I said, we don't get clean in a vacuum. We need others. The continuity of care, that we're not talking about one episode or one dose of something. We're really talking about a full continuum. That it's strengths based. Find that thing that that person does well. And, resilience is a huge one. I mean, as a recovering person, I can tell you addicts are the most resilient people in the world. That it's culturally responsive, that we're acknowledging and honoring someone's culture of origin, what traditions they believe in, what things anchor them. Partnership and consultant relationships are important. So, sometimes it's important to bring in a peer in a clinical setting to help connect to somebody on a different level. And so building as many partnerships as possible with services, with clinicians, with peers, with faith community, all those relationships are really important for creating a place where there is recovery management. Um, Individualized and comprehensive. So each person is their own individual. They are an expert in themselves. They know their history. Commitment to peer recovery support services. I can say that many times when I speak as a person in recovery as opposed to as a clinician, I make much more headway with someone because they recognize that I really do understand and that I have felt those feelings. Inclusion of those with lived experience and their families is really important. And families have their own lived experience with their loved ones who have been struggling. And we had, a lot of uh, words like tough love, tell them he can't come in the house, all these things we've told people to do. And, it's time to have a paradigm shift and really talk to people about what does recovery look like for your family, for the individual, for the parent, for the child. So recovery management has guiding principles, and I hope that all of you add to these, based on your own ethics and your own clinical practice and what you are learning and how you reflect. So these four stages of recovery: pre-recovery identification, which is also termed recovery priming, really helping somebody visualize what recovery might look like for them. Initiation and stabilization, it may look different for each individual. Transitioning to successful recovery maintenance. So what does that look like? I've met people that going to church and having a really good workout plan works for them. And so, being individualized is important, and helping people share and experience what works for them is really important. Enhancement of quality of personal family life in long-term recovery. Just because I got clean didn't mean I was well. I really had a journey of trying to explore my relationships with others. I didn't do well in therapy until I was ready to do well in therapy, and I had a lot of demons to address. So, it's not a sprint. It's definitely a long journey. We also talk about the term recovery capital, and recovery capital is really looking at the breadth. So we're looking at physical, um, family, and community. So physical recovery capital refers to, human capital. Does someone have a home? How's their health? What kind of assets do they have? Their finances, their purpose, their job, their education, family and social recovery capital. And so who are they surrounding themselves with? For me, I have a lot of friends in recovery that know more about me than many of my family members do because I share with them on a different level. I know that they understand. And there's people that in my world will show up for me, whether I'm celebrating my clean time or whether I'm really struggling, because I'm here to tell you, I'm 34 years clean and I struggle sometimes. I've seen people with 25 years just go out and have a drink and throw it all away because they got isolated and they thought, they couldn't tell people when they were hurting because everyone looked to them. And so, any one of us is one bad decision away from, throwing a lot of things away. And so having a strong social network is important. And then community recovery capital. We have a bit of work to do in our community about attitudes and policies and the resources that we provide for people who are struggling with addiction and recovery. It's reducing stigma. It's looking at some of those practical things. I worked with a woman just recently. She ended up getting out of a treatment environment. She went in a hotel, and that hotel was such a trigger for her. It seemed like a safe place, but when talking with her, she said, it just brought me back to everything. And the obsession was so great. I went out and I used. Um, Really, having um, that breadth of resources available when we're working with somebody so that we can look at the person as a whole. And it may include things like childcare, helping someone with some of those real practical things that they are going to need, job training, um, getting their teeth fixed so that when they go on a job interview, they can smile. There's so many things. And also relapse is a part of recovery. Um, you know, People need to feel like they can come forward and say, I slipped up, I went out, I had a drink, or I went out there and I need help getting back into my recovery mode. Protective factors are super important. You'll see different versions. One is 6 protective factors, and in some models you'll see 5 with nurturing and attachment as an overarching theme. But focusing on the family, helping families become resilient, helping them understand how to parent and what child development looks like. What is a child's expected milestones at age 2 or age 5? Or, we have a lot of women coming into recovery who have grown children also, or children who are adolescents, and they say, oh my gosh, they're so annoying. And explaining to them that they're in their second stage of separation, that they are trying to learn how to not need you. So it's not personal. Anybody who's had a teenager knows, they're a whole different parenting experience. Concrete support in times of need. Everyone needs help sometimes. We don't want any woman, any recovering person to avoid saying, I need your help. We need to be there to listen and to find out what kind of pathways we can give people to finding the concrete needs that they have so they can be fulfilled, whether it's housing or childcare or food. Positive social support. We all need social connections. Isolation is the enemy in recovery. And social and emotional competence of children. And I think this one's really important because we need to help children communicate. And if as adults we struggle with self-regulation and communication, it may be really hard to help our children learn how to communicate. Even babies, when they cry, they're communicating, and helping parents realize their child is not being bad, their child is not trying to be annoying or fussy, the child is trying to communicate. And, all of us as parents are better parents when we're trying to listen to our children's cues, find out what they need from us, provide boundaries, provide stability, but also respond when they are trying to communicate to us. Um, this is mostly used in child welfare. It's really used as a risk mitigation tool. And as we saw in the ACEs, it can counter negative health outcomes. And it's really working to break the generational cycle. We can really do a lot to kind of interrupt that. I don't have to be my mother. It took me a long time in therapy to realize that when I needed some nurturing, my mom was not the one to call, right? But I met women in recovery who were very nurturing, and they helped me learn how to nurture my children. Individualized capital, each person has their own superpowers, you know. I haven't met anybody that doesn't have some really amazing talent or something they're good at. Um, Social, physical, human, and community is, you know, how they interact with all those things is important, and aligning it with SAMHSA's uh, 4 dimensions that we talked about earlier. Mostly utilized in recovery management and behavioral health services. We want to reduce recidivism, relapse, and earlier reentry if necessary. And again, we want to work to break that generational cycle. Um, and we also want to make sure that anyone we're working with children knows where to go to get the help and services they need. I also, Circle of Security, wonderful parenting program that we've used that has shown a lot of success in helping parents recognize how important it is that they be the safe person in their child's life. So we want to help them build protective factors. We want to create safety for the child. We want to promote resiliency, promote positive parenting, and address shame about previous parenting experiences. We don't want parents, especially those with older children, to move into recovery and then parent their children out of guilt. Children still need stability. They still need boundaries. They need to have a safe world around them that's predictable. So we want to make sure that parents in recovery don't feel so guilt-ridden by things they put their children through that they parent from that place of guilt. And then address and support effective co-parenting, because a lot of times there's a partner out there he may or may not be using, and fatherhood involvement we've seen from research is really important and it's significant. So figuring out how to help people co-parent successfully also is important. So we talked about these protective factors. I encourage you to learn more about them. I encourage each person to live in the protective factors. Look at your own life and realize how you build these protective factors, because they are the mitigating factors to all that risk. We can't take risk away from people. I can't change anyone's past experience, but we can sure help each other build protective factors. Parent cafes are wonderful social gatherings where we use the protective factors and conversations parents can have with each other to help build social connections and really talk about some of the challenges of parenting. Without a substance use disorder, parenting can be difficult. It uses tools for parents that were developed by parents. It helps build social connections, and it's sort of that um, oh, there's also an experiential evaluation for the past decade of parent cafes. So if you want to look it up, go to Be Strong Families. They have great materials, and I have attended so many parent cafes I can't even tell you, and I just love them. Risk resiliency and protective factors. So the ACEs study showed us that adversity is more prevalent than we had thought before. We can't change risk that people have experienced, but the presence of protective factors can be those mitigating factors. And as our systems learn ways to build protective factors among all people, we can change the trajectory for the people that we serve in relation to health, emotional well-being, and relationships. And I'm here to tell you it's all about relationships. It's one of the hardest things to uh, to counter. I've been married 30, let me see, I've been married 32 years, and there have been some very difficult times. And a lot of them were me having to learn how to become well and relate on a more mature basis. I had to learn emotional maturity. And so, you know, so do our systems. Our systems need to evolve and learn how to interact with people in a supportive way that's non-judgmental and non-shaming. I thought this was a really cool slide because, you know, the adverse childhood experiences countered with resilience results in success and greater success. So you can see you repeat less grades when you're more resilient, you miss less school when you're more resilient, and you engage more in school when you have resilience. So we also have a resiliency score, which is much more fun than the ACEs score, but it really connects to things like feeling important and loved and hope. So these are the resiliency score questions. I believe that my mother loved me when I was little. I believe my father loved me when I was little. Other people helped my mother and father take care of me, those social connections. I've heard that when I was a baby, someone in my family enjoyed playing with me and I enjoyed it. When I was a child, there were relatives in my family who made me feel better if I was sad or worried. When I was a child, neighbors or my friends' parents seemed to like me. When I was a child, teachers, coaches, and youth leaders or ministers were there to help me. Someone in my family cared about how I was doing in school. My family, neighbors, and friends talked often about making our lives better. We had rules in our house. So I encourage you to check your own resiliency score and also connect it with someone's birth story. How did they hear about how they arrived? And, do they believe that they can succeed? The plans of safe care, I just think everyone should be aware. I'm not going to go in detail in these, but this was a result of legislation. We have an obligation to make sure that the infant and the mother are safe. And it was connected to the CARA Act, the Comprehensive Addiction and Recovery Act, and it's linked to a DCF policy and procedure that most of you should be familiar with. But basically, it changed the way we report incidences of substance exposure. It included families and caregivers in the plan, and it took away the word illegal because we know that substances that are legal, including MAT, methadone, prescription drugs, alcohol, can still have an impact on someone's ability to care for their infant. So these are some of the elements that are addressed, and I did give you the DCF policy so that you are free to check it out on your own. So these are some of the resources we have in recovery. I love RAP. It really asks people what they're like on their best day, how they can develop tools to stay well, how can they remind themselves to use those tools, how do they plan for a crisis, and what are early warning signs that they may not be doing well. And this is a fave for me. There's a RAP app. You can go and have your own RAP plan. They go well with the plans of safe care. Also allows us to check in on a plan of safe care through using the RAP model. So I encourage people to become familiar with that. Smart recovery, I don't see a lot of them in the state of Florida, but it's a 4-step process. And it really, for people who struggle with that concept of higher power or being powerless, this has been a positive option for them. The seeking safety model was developed from my really focuses on the overarching goal of behavior and its management, and it pays close attention to the clinician's processes. 12-step programs, they're abstinence-based in nature. Different groups in NA or AA may have different attitudes toward use of medication-assisted treatment, and there's many of our anonymouses. A lot of people get clean in the 12-step world, and I am an active, attendee in 12-step programs, and they're not for everyone, but they have huge success. Also, you should know about recovering communities, and these are independent nonprofit organizations that are governed by representatives of local communities of recovery. Floridians for Recovery is here in our state. ARCO is an overarching group, and it brings a lot of types of peers together in an organized structure. When we present to somebody their options, we want to look at their history, housing, what's worked before. We want to make sure we know what treatment services are available in our community for them so that we can really explain a menu of their options. And then we really want to be able to put it all together for ourselves. Integrating concepts help us connect in a more meaningful way. Reflecting on how we personally relate to these things is important. Giving someone options. I don't know about you, but I like, making choices and not being told exactly what I need to do. Be mindful of our own responses. Be aware of shame and stigma and know where to find resources. So the following resources we should keep well at our disposal: where peer recovery services are, drop-in services, resource centers, where the 12-step services are. You can get all of those online. Domestic abuse services, human trafficking services, and for infants and children, we need to make sure we're connecting to early steps, WIC, CMS, residential services that include infants and children, FASD, which is fetal alcohol spectrum disorder, childcare, and there's so many more, but keep your directory close so we know how to connect people to resources. And, I put something in here to just help people connect to self-care. Please reflect on your own biases. Consider women's right to self-determination versus societal expectations. We may all have beliefs about pro-life, pro-choice, reproductive health, and we really need to help a woman focus on what she believes and what she is seeking for herself. Always consider for yourself a self-care plan. We need to have empathy for people that we work with. This is a self-care wheel. It's really just for you to use. I encourage you to develop your own self-care plan using the wheel. I'm not going to go over it. I just wanted to provide it as a resource for you because we work hard in this field and you all are doing great things every day and you are exposed to a lot of other people's trauma. So take good care of yourselves. So think about how you nourish yourself. Think about how your ability to practice self-care is impacted when you relate to others. And think about what you can do today that can help you with some balance in your own life. One more film about stigma. It's short. Okay, so we're about out of time, so we'll deal with questions maybe outside of the chat room. I want to thank you. You can make a difference in the lives of moms and babies and our families. There's a lot of resources, so there's 3 pages worth. Some are web links, some are videos, and some are articles. They're all available for you, and you can access this PowerPoint afterwards. So these are your web resources, your video references, and your article references. So thank you very much for allowing me to spend time with you. All yours, Rebecca.
Thank you, Dixie. We have included Ms. Morgese's contact information so that you may contact her with any further questions. Dixie, we really thank you for all the work you put into today's webinar and the valuable information you shared with us. Please note a couple of items of business before we conclude. Please see the chat panel for a link to today's survey. Additionally, when I conclude today's webinar, your browser will take you to an evaluation on FATA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE Broker, Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FATA's system. This help connects your attendance with your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. The sender will be messenger@webex.com. Evaluation will close at midnight, Friday, October 1st. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 days after the evaluation closes. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day and please hold for the evaluation.